Unlike the usual neurology, it will be a little different because most of the neurology conditions, short duration problems. This is happening over years and lot more than pure neurology. Lot of social aspects, other situations need to be discussed. The discussion in an exam-oriented manner and the other way, real case when you are a pediatrician. So today, we'll be giving a little more stress how to do it in an examination, a 40 minutes, how to do it. That will be a highlight of this thing. A little more time you are getting, so we'll be touching more on the other parts also. Anyway, let us hear. Sandra, you just start presenting. Present. Slowly, you read the history.
Good afternoon, all. Presenting case of Anthony, a 10-year, 2-month-old. Is my screen visible, sir?
Yes.
Presenting the case of Anthony, a 10-year-old, 2-month-old male child from Varapura, Ernakulam. The informant is the mother and history is reliable. Presenting complaints, he is a known case of developmental delay who presented with fever for 5 days, cough for 3 days, fast breathing for 2 days, and left ear discharge for 1 day. History of presenting complaints. This 10-year-old child, who was a known case of developmental delay, presented with fever
I'll stop here. Just at the first slide,
yes,
there is a purpose for this thing. Many of the situations, a patient with a development delay will be coming to you with one of these complaints. Common one is an respiratory problem. Another one is a seizure status epileptic situations, or one of the acute scenarios. So the main focus will be to stabilize the child. So in an examination, it's always, it's not history followed by examination and all. This is one situation where the stabilization is more important. Before you proceed with the entire details and all, see the vital signs. Maybe there it is in the general examination part. Oh, mute it's disturbing. എല്ലാരും മ്യൂട്ട് ചെയ്തിട്ട് അതായിരിക്കുന്നല്ലോ ശരിയായോ ഓക്കെ okay so when the first thing in a case coming like this will be to ensure the patient is stable clinically, then only proceed with the examination. Okay, proceed.
You are muted.
Sandra, unmute. You can unmute. Continue.
History of presenting complaint. This 10-year-old child, who was a known case of developmental delay, presented with fever for 5 days, which was insidious in onset, moderate grade, intermittent, not associated with rigors. It was associated with cough for 3 days, which began after the onset of fever, which was intermittent, dry cough with no diurnal or postural variation, and not associated with nasal discharge or post-tussive vomiting, and no relation with food intake. There was history of fast breathing and chest and drawing noticed by the mother for 2 days. History of left ear discharge, which was yellow, purulent, non-foul smelling, noticed for 1 day. It was associated with increased irritability and crying for 1 day. As the child has a developmental delay, I would like, and is bedridden, I would like to start from the antenatal history.
Okay, 1 minute.
Yes, sir.
Here again, there is a problem. What should be a better method of presentation in a case of development delay? The method you started with the presenting complaint. There is another method. You can start from the starting from the antenatal period onward, the entire history together. Which one is better? Sometimes a few of the examiners likes the other way. So maybe if they want the other way, you can go for it. Both ways you should be ready for it. But when you're depending upon this thing, the mental presentation will be the total history and this episode, one of the status seizure situation or a pneumonia. If this method you will be elaborating, taking more time on the history of the presenting illness, that will be spoiling your time for the evaluation totally. So the other method will be better. There again, you need to have a time management if it is an examination. So how you are going to be affected by this long history is in any developmental delay problem, let it be a delay or regression, stepwise in the history analysis only you will be answering, is it a delay or regression and all. So the entire history taking and the evaluation is happening simultaneously. It's not history followed by the evaluation. So the moment you see the child, the evaluation also starts and you will be interacting, taking history and all. During this period, your eyes are screening what the child is doing, all the activity, postures, interaction with the mother. And it can come in a range of situations. Maybe the child may be coming walking to you, and it's a totally bedridden child. Another may be in between, lying, but he can sit up. So all these things you are observing. Actually, a developmental delay cannot be approached or discussed in one session or one teacher. It's just like five blind people looking at. I am looking at the elephant from one side. It's my version, just a portion of the reality. Maybe another situation, another case, it will be totally different. The approach will be different. The actual case scenario, the management will be different. So we need more and more number of cases evaluation, then only we will be thorough with the development delay. Unlike any other case, it is such a vast case situation. So, in short, when you're taking a long history, don't be immersed with the entire negative histories. Lot of time you will be spending on the negatives, especially when you're writing. You can afford to ask and get the history, important negative points, but during the writing, what is needed is only relevant the positive things you need to write. Otherwise, the time management will be difficult. So, 2 points, history and examination together, and your assessment of all these things are doing at the time when you are taking history. That is one part of your saving time. Another is you are going into history, but the writing is only the positive things. No, list did not be written. That will take your time. And okay, you go ahead. And one more thing, the whole purpose of your examination, history, examination together is to answer sequence of questions. Like, one, is there a delay? Is it a delay or regression? If it is a developmental lacking, which all fields are delayed? One field, more than one field, global. And then if it is a static or a regression situation. And then the other thing, what is the type of the problem, like anatomical, physiological, functional aspect of this problem. Neurology axis will be affecting the different parts of the brain, which will lead on to problems. So you are going to define the neurological aspects in the form of an anatomical, like topography of the involvement. Second thing is the physiological. What is it? It's a spasticity. It's a hyper extrapyramidal or pyramidal or a combination. So then, what is the etiology behind? And last thing, what about the functional disability which has occurred in different fields? And the last thing, what are the comorbidities associated? You're trying to find the answers to all these questions by analyzing both history and the examination. So whenever you are going forward with the history analysis, you need to consider these possibilities. Each point in the history is useful for answering few of these questions. So any of these things, here it's a 10-year-old, 2-month-old child with a development delay. And that may not be the problem if it is a 1.5-year-old child with a development delay. So age is important, sex is important, and the mother's education status is important. Few of the questions are relevant for rehabilitation situation only. Few of the questions are relevant, points are relevant for the associated things. So when you move forward with the history, you keep an eye on this aspect. Okay, go forward.
Antenatal history. Third child of non-consanguineous marriage, born to a 31-year-old para-2 living-to mother and a 43-year-old father. There is no history of previous abortions. She was a booked case and regular antenatal checkups were done at District Hospital, Aluva. In the first trimester, folic acid was taken, injection TT was taken, first trimester scan was normal, no history of fever with rash, no history of spotting PV, no history of radiation exposure or any other drug intake. In the second trimester, quickening was felt at 5th month, history of PIH and oral medication, antenatal scans were normal, no history of gestational diabetes or antepartum hemorrhage, adequate weight gain was present during pregnancy, and calcium and iron tablets were taken. In the third trimester, a weight gain of 10 kg was present during pregnancy. The antenatal scans were normal, no history of spotting PV or leaking PV or UTI, no history of foul-smelling liquor or high-grade fever. The mother was admitted at 32 weeks gestational age in view of uncontrolled high BP. She had decreased fetal movements at the time. At the time of admission, she was advised to do a daily fetal kick count, which she perceived as low. However, no intervention was done. At 33 weeks gestational age, she developed facial swelling with high BP and poor fetal movements, hence taken up for emergency cesarean section. Birth history. The baby was born very preterm at 33 weeks by a cesarean section in view of preeclampsia and fetal distress with a birth weight of 1.59 kg, cried soon after birth and was admitted in NICU immediately after birth in view of respiratory distress. There is no history of meconium stained liquor. Expressed breast milk was initiated 1 week later and handed over to the mother's side on postnatal day 8. Baby started sucking at breast after 2 weeks. The mother was not aware of when the baby first passed meconium in urine. There was no history of cyanosis, neonatal seizures, hypoglycemia, jaundice, and no invasive procedures were done according to the mother. The mother's blood group was B positive. There was no history of blood transfusions or phototherapy, no congenital malformations noted, and baby was discharged from hospital on postnatal day 20. At the time of discharge, the baby was active, passing urine and stools, and sucking well at breast.
Okay. You have completed the antenatal, natal, postnatal history, including the starting from the birth status. Out of a non-consanguineous marriage to a little higher age group, father was 40 at the time the baby was born and 31-year-old mother. There was one history of abortion. You didn't mention about which phase of the abortion. First trimester abortion is more important. It's a non-consanguineous marriage. Whenever there is an abortion, you need to mention about that also. Is it a first trimester abortion or a last trimester abortion? Then the antenatal history. When you present in the examination, actually the list of no's need not be mentioned when you are writing. You can ask it. But for purpose that serve, whether there is an injury to the brain, developing brain, which happened during first in the antenatal, natal, or postnatal, because when you are evaluating a developmental problem, you will be answering what is it? Is it a static disorder or a progressive disorder? There may be situations where it's not clear cut. There are few of the progressive disorders, regression, neurodegenerative disorder, which cannot be, sometimes cannot be subtle findings only. So like your diplegic CP and arginase deficiency and dystonia development, this dopamine dystonia and all are CP mimics. In such a situation, you need to depend upon this question. Is there any insult during the antenatal, natal, postnatal, which is obvious? That's a point to support that it is likely to be a CP. In a context where none of these phases there was any injury, but unexplained situation of the developmental problem, you need always to consider, am I missing another condition and taking this as CP? So that is important. So that is what is the idea in your mind when you're taking all these things. In this case, what was the overall summary? Positive finding, you got the 33-week premature baby, but AGM. The weight was adequate for a 33-weeker. So preterm delivery, that is one thing. And the baby had a stormy picture during that period. It was an NICU graduate. That is one point. Of course, in the later thing, that is arguing for your possibility of a cerebral palsy. One more thing it will confuse you is, first I told the degenerative or regression process confusing you, you're taking it as a static disorder. The other way also is possible. Few of the static disorders, after some time, there can be a regression. So that's also possible. So both situations, that is pseudo regression. In a static disorder like adolescents gaining weight overweight, some other situations, so you may take a static disorder as a progressive one. The other way also is possible. In all the situations, your insult to a developing brain any time, out of which most important is antenatal, natal, postnatal, early period. So in this case, there is a definite injury that is in short, which will be arguing for your later evaluation. This is one point for suggesting static disorder CP. Suppose when you evaluate later the static disorder, but there is no perinatal insult, there are other group of conditions again behaving as static disorder. What are the other ones? Genetic disorders, intrauterine infections, some of them malformations. All these things are also static disorders, but the main difference between these static disorders are, you go back to the definition. The problem cerebral palsy is a problem of posture, movement, tone. So if they are spared and features will be others, you need to consider other static disorders. It is not supporting the CP. So in short, antenatal period, there was a significant injury to the insult to the brain. A few points, I think, which you have missed in the newborn part. About a little more elaboration is needed. You go back to this thing. On the day of delivery,
yes, sir.
Whether the insult is proportionate to the later problems also, what is another problem? There can be a subtle injury situation, but when you follow up, it cannot account for the growth delay. That is one point which is very important. So to what extent was the insult to the brain happened in this case? You go back 33-weeker only, 1,500. It's not that bad, but the baby had a distress. So how was the level of management? What was the level of management in the ICU?
The mother is not aware of the management done in ICU. According to her, the baby was not sucking and was not active. Hence, the baby was started on tube feeds for the first 1 week and then expressed breast milk she was asked to give. And within 1 day, the baby was handed over to the mother and started on Gokarna feeds.
Rather than giving a list of no's, cyanosis, no neonatal seizures, much better will be the other way. Because whether there was a HIE situation in the day one, that would have been much better. Here, you told about the admissions and the feeding problems and the respiratory distress. Naturally, a 33-weeker may be having a respiratory distress situation, needing on varying levels of the respiratory support. That doesn't mean that the brain injuries happen. So the features of the brain injury on day one and the initial days are the forecasting the later neurological problems. So whether there was a first day, what was the situation? In a very severe later sequelae, usually the encephalopathy, the ischemic hypoxic injury will be predominant, and the baby on day one will be having usually Sarnath convulsions. In this, that situation was not there on the day. Was the patient on ventilator on day one?
No, sir. According to the mother, no.
So it seems that the baby was not that, the cerebral insult was not that much in this case to account for a major delay. And one more thing, during this period, in the present situation, maybe not in 2011, almost 10 years, 2013 it happened. Okay.
Yes, sir. Yes.
So 10 years back, there are few of the neonatal screening programs for these babies. Those things you need to mention. Whether any screening programs were done, whether that was abnormal during this period. And this sort of babies also, there is a guideline for follow-up also.
Yes,
so
sir.
those things you didn't mention. That is important. Salabam program started from 2012, and many of the other screening started earlier also in our state. So Salabam onwards, a lot many neonatal screenings are there, especially for these babies, and there is a clear-cut guidelines for the follow-up of the premature baby, about the ROP, about the OE. All these things are important when you're. And
Yes, sir.
And recently, few more things. Early marker of the CP situations in what we learned at that period was there are a few points which will need to be asked, starting from the newborn period up to the maybe few weeks. But here there are a few new things like the analysis of the abnormal movements of the newborn baby. So that can be done by an expert only, that can forecast this sort of a problem. And few more of the insults which may be contributing to that. Not only this insulted happening during the delivery, asphyxia problems, later complications like hypoglycemia, like neonatal infections. Another thing, neonatal jaundice. You mentioned about the jaundice part. I see bleed.
Yes.
So there can be more than one insult. Maybe in another case, many other things must have added on to the insult, like your baby transport, how was the baby transported, all these things will be leading on to the net result, because you are going to answer two things. Perinatal insult that will arguing for the concept of CP. Second thing, the type of the abnormalities, and this should be correlating. So to correlation, the severity of the insult should be correlating with the sequelae. The type of the problem should be correlating with the neonatal insult. If you are getting a hypoglycemia, of course, we know the cerebral visual impairment and the blindness. And the prematurity only, you are getting the diplegia. So depending on in the toxemia, what you expect is usually a hemiplegic type of CP. So that also is important in the evaluation, the first month. Sushma, madam, anything to contribute? Das, Dali, or anybody? Madam is there? എല്ലാരും മ്യൂട്ട് ചെയ്തോ? Proceed, Sandra.
The first year of life, baby was taken for routine immunization at 6, 10, and 14 weeks, and there was a constant gain in weight. At 2 months of corrected age, the baby did not attain social smile. At 3 months of corrected age, child had not attained neck control. They consulted a pediatrician regarding the same. They were reassured that this was because the baby was born preterm. At 4 months of corrected age, the child did not attain neck control or smile, but rolled over like a log. Mother noticed that the child did not look at the mother's face and did not recognize her. At 8 months of age, the child developed episodes of sudden bending forward of the head with stiffening of upper and lower limbs lasting for a few seconds. Such episodes were noticed 1 to 2 times per day. It was associated with excessive crying. After the episodes, there was no drowsiness or poor feeding. They consulted a homeopathy practitioner for the same and were started on medications. In view of persistence of symptoms, they consulted a pediatrician. EEG was done, which was told to be abnormal, and they were advised by the doctor to start medication. The parents were not willing to initiate treatment and returned to homeopathic medication. The frequency of symptoms gradually increased to 8 to 10 times per day. At 1 to 2 years of life, mother noticed that the child had decreased spontaneous movements of all four.
In the first part, usually the examiners will be more interested in the early weeks in the neonatal period. When any baby high risk prematurity neonatal stomy picture, you are interested about the follow-up. So you will be asked about whether there were any early markers of the CP situation. I said in the newborn period itself, some abnormalities in the movement will be. After that, few more things: excessive cry, problem the sleep. Few points you need to mention. In this case, it is not the.
Yes, sir. There was history of increased irritability with excessive crying. There was no history of poor sucking and no history of poor feeding.
So initially, how long the baby was fed with the tube? Only 1 week.
Only 1 week, sir.
Okay. First week it was IV fluid, and then started on 2 feeds. And at the time of discharge, baby was on
breastfeeds, direct breastfeeds.
Direct breastfeeding. It was tolerated at that time. And gain in weight was documented.
And gain weight was documented.
Okay. Okay.
At 1 to 2 years of life, mother noticed that the child had decreased spontaneous movements of all 4 limbs. However, the child was able to move both arms and legs. She had also noticed that the child would always keep the palms closed and would rarely open hands at 1 year of age. The child did not attain neck control, no history of poor sucking at breast, no history of early hand preference. There was no history of
difficulty. So this all will be more confusing. You are depending more on no. So when you are writing like that also, you are contradicting yourself. See, there is no history of hand preference you written here. Actually, you go back, the child is never opened his hand. There was a contradicting thing. So you are contradicting just because you wanted to give a list of no's. So better avoid this thing and go forward with this thing. A child who is having a significant problem, not even achieved open hands at this age. So what's the question of this hand preference here? Okay.
There was no history of difficulty in wearing diapers or crossing of feet when held upright. No history of slipping between the mother's hands.
Again, that's another thing. You are contradicting the. Actually, you don't expect that. All the other things are spasticity. A spastic child, you don't expect the slipping between the hands. Okay.
There was no history of any abnormal odor of body or urine, or history of recurrent vomiting or failure to gain weight or worsening of illness during fever.
So in the initial months, one thing is very important. Child started taking breastfeeding and the weight gain was normal. That is a point which is very useful. Arguing against what?
Neurodegenerative or an inborn error of metabolism.
2 things. Intrauterine infections are less likely. Second thing, early onset neurometabolic disorders. It's not neurodegenerative. Many of the neurometabolic disorders starting very early, the failure to thrive also will be accompanied. Child had a very good gain in beta cotton. Okay. And one thing, below 1 year itself, somewhere around 8 months, started having a type of seizure, which is what type of seizure you described at that time?
Sudden bending forward of the head.
Which type of seizure it looks like? Lasting for seconds only?
It could be an infantile spasm.
You need not tell about infantile spasm. It's a myoclonic jerk. In the context like this, why I didn't agree with the infantile spasm?
Because if it was infantile spasm, that could attribute to neuroregression. And there is no...
It's not a regression from that period. Actually, no, nothing was attained. So even social smile, head control, nothing was attained. In such a child with the perinatal insult, you're getting a myoclonic type of seizure. We need not always consider this the West syndrome. There are many other reasons also. One of the commonest one is HI itself. HI itself can lead to myoclonic seizure. What are the other conditions where you can get a myoclonic seizure in a infancy? Next one, of course, is HIE. Then, as you said, without any other problem, it's starting all on a sudden from around 4 or 5 months. It is a West syndrome and intrauterine infections. Very important. And few of the migration disorders like your corpus callosum agenesis, and few of the metabolic problems like phenylketonuria. So these are all list of the conditions which you need to consider. But here, first thing, of course, in this scenario is part of the HIE itself. You can get a myoclonic seizure. Need not go to the other problems. But there is one important possibility. There can be a situation where otherwise you consider a static disorder CP, but there can be an underlying problem like your migration disorder or a malformation is reason for the static disorder CP. So in such a situation, they are more prone for the basic manifestations like myoclonic seizure. So we need to consider that also in this. Okay.
Yes, sir. Second year of life onwards, from the age of 2 years, mother noticed that the child continued to develop abnormal movements, but with a different semiology. The new episodes were associated with uprolling of eyes and stiffening and jerking movements of bilateral upper and lower limbs, lasting for 1 to 2 minutes. After these episodes, the child was drowsy and would sleep for 1 to 2 hours. They consulted a pediatrician for the same. MRI brain was done, EEG repeated, and they were informed by the doctor that the child had developmental delay and would not be able to perform like other children and would require supportive management.
When you mention here, another type of an abnormal movement started occurring in the second month. Of course, you need a seizure, but always you need to clarify when you're talking about abnormal movement. Is it a seizure? Because very likely that this baby can have a real abnormal movement also. From what I said, sequentially you are trying to answer what type of disorder, static disorder with a problem with the posture and movement, and maybe it's the CP itself. In the CP, what type of a CP? Is it a purely pyramidal type of thing, or is there any extra pyramidal? So maybe the abnormal movement like picture may be starting somewhere like this also. So in this case, you need to have a description of what type of movement it is, whether it is fitting with a seizure or another abnormal movement. In that situation also, what type of abnormal? Different types of abnormal movements are possible. The posturing, dystonia, it can be chorea type situation. So few of the part of the cerebral palsy itself, it becomes mixed type. Or maybe you need to consider a progressive disorder starting and you are mistaking that for a CP. So you need to describe what type of abnormal movement it is. In this case, it suggests more of a CP. What is the point which suggests more of a seizure?
There is post-episode drowsiness and the child will
There's a
sleep.
drowsiness and sleep following this one, and it is a jerky type of a movement, uprolling of eyes and stiffening. All this suggests a seizure, but it's another semiology. So more than one type of semiology of the seizure this happening. So that also is important. When a child like this is this developing seizures and another type of a seizure, there will be an underlying problem of migration disorder. It need not always be right, but you need to consider that point. Okay. So anyway, they didn't take the medicine. They were advised. Okay.
They were advised. They were prescribed medications for the same, but was not initiated by the parents. Similar episodes were present till 2.5 years, after which they were controlled with homeopathic medication according to the mother. The mother is not able to recall the frequency of such episodes. Homeopathic medication was also stopped gradually. There was history of difficulty in wearing diapers from the age of 2 years, and mother noticed increased stiffness of all 4 limbs. They were advised to do physiotherapy for the same, which was continued at home by the mother. From 2 to 5 years of life, the child was taking feeds orally and fed by parents. He also had adequate weight gain according to the mother, did not achieve bladder or bowel control. He remained bedridden and fully dependent on his parents for dressing, bathing, and grooming. He was enrolled at a special school to get financial help. However, they stopped after 1 week as the parents were apprehensive. Physiotherapy was continued at home, but he developed contractures at both ankles, elbows, hips, and knees. 6th year of life. At 6 years of life, the child choked while being...
Previous slide. So I was talking about each of the sentences when you are hearing, you need to answer what way this point will be useful. We are asking, we are going in a systematic manner, defining the problems, physiological, and the how much is the problem affecting him in his day-to-day, what level of support he needs, say about the day-to-day activities like the feeding and the other aspects of grooming, so that who can be involved in this, in the management, what is deranged, who can help the all these things which you have mentioned about the feeding orally fed by the parents, and what is the method of feeding, how much duration it takes for feeding, and what is the items he can accept. Lot many things are needed, because in the classification of the disability problems, there are 3-4 scales which you are applying. The application is from the history points. How much is the mobility, gross motor, functional classification that you get from the history? How much is the manual ability, classification you are applying from this history? Whether he's, in this case, the hands are not open. So manual ability, will there be anything possible with the hand? That will be applicable only when his hands are open, he is coming and using and using. So such a situation, how to improve the occupational therapist, how can he help him for self-feeding? So that's all based on the support he is getting in different fields, about the manual ability of the scale and the communication. Okay, and eating and drinking, another classification scales are there. So all these scales you are applying when you hear all these points. So that's the importance of all these points. You need to consider, and you see the hands and this is photo. There is a particle twisting obvious in the upper limb. Okay, both
Yes.
forward.
Sixth year of life. At 6 years of life, the child choked while being fed, following which he developed bluish discoloration of face and lips. Child required ICU admission and oxygen support. During the course of hospital stay, the child developed multiple episodes of seizures, was started on medications for the same and discharged after 1 month of hospital stay. But child continued to have abnormal movements at home in the form of eye fluttering with deviation of face to either side and stiffening of bilateral upper limbs lasting for 1 to 2 minutes, which resolved spontaneously. Child had 2 to 3 similar episodes per day while on medications. However, they did not consult doctor for the same. Seventh and eighth year of life, due to COVID pandemic, the child was not brought to hospital. From 8 years, the mother also noticed that the spine of the child gradually deviated to the right side. Physiotherapy was discontinued and the stiffness of all four limbs worsened. His oral intake decreased because of difficulty in swallowing with frequent regurgitation of feeds, and he was not gaining weight. Ninth year of life, at 9 years of age, the child developed fever, cough, and fast breathing, again following a choking episode, and required ICU admission with O2 support. Feeding was initiated then by a nasogastric tube. The need for physiotherapy and occupational therapy was reinforced to the parents, and the child was discharged after 1 month on RT feeds and supportive medications. Following discharge, the parents switched to Ayurvedic medication and continued anti-seizure medications alone. They visited hospital twice in a month from then to change nasogastric tube. 9 years till date, the child is not ambulant and feeding via nasogastric tube. He is fully dependent on his mother for all activities of daily living. Physiotherapy has been stopped and contractures have developed in all four limbs. He does not speak except for occasional moaning. The frequency of episodes of abnormal movements gradually decreased to 1 episode in 6 months after starting medications. He does not recognize faces. He does not look at light or follow moving objects. There is no history of abnormal movements of eyes or squint, no history of facial deviation. He responds and turns head to mother's voice. He is able to swallow, but frequent history of choking present, history of drooling of saliva and nasal regurgitation present, no history of nasal twang to the moaning voices. Child is not able to lift head up from the level of bed or turn in bed. He is not able to hold objects or lift arms above the level of head while lying down. He is not able to move legs sideways or lift leg upwards while lying down. No history of twisting movements of the limbs. He is able to appreciate the pain of injections and able to appreciate warm and cold water when given a bath. He passes hard stools once in 2 days. No history of aggressive behavior towards others or self. No history of bed sores. No history of vomiting. No use of aids or assistive devices.
Okay, and till now, you are trying to answer the different affection of the neuraxis producing different problems. Whatever problems were there, the higher level is almost nil. The cognition part is almost nil. There is a visual problem. Hearing, it is responding, and the lower part, the cranial lower part, there is a problem which is swallowing, drooling, frequent aspiration is there, and significant affection of the limb motor part. And you can't say the more details about the sensory things except is appreciating the pain sensation. But in a CP, main share is the motor part. But there can be a little bit of cortical sensation that in this case it's not possible. So to what extent is the neuraxis involved is one thing. The second thing, the involvement of the musculoskeletal system due to the neuraxis involvement. That will be affecting the muscle shortening, involvement of the capsule and the ligaments, leading to varying ranges of the musculoskeletal and the deformities. To what extent it is gone is to be assessed to decide who are to be involved in the management. A situation where already contractures and the deformities of the bone has occurred, that means orthopaedics are needed. The bone deformity has not occurred, but contractures, the surgeons and plastic surgeons are to be involved. It is yet to involve the shortening. It's only the spasm. The physiatrist and physiotherapist and those people are to be involved. And that's not to be decided by the history and the general examination evaluation. So that is what you are doing with the history. Sushma, madam, any comments, madam? Madam is not there. Dr. Ali, Dr. CG, Dr. Das, anybody, any other opinion?
Sir?
Any points? Any points?
No, sir.
Okay, we'll proceed.
Development, gross motor, no head control, fine motor, no voluntary grasp, language, no vocalization, social, no social smile, vision, no fixing or following light, hearing, alerts to sound. Child has a developmental quotient of 0 in all domains.
So this is one of the worst situation you can get. And difficulty in discussing this case also is due to this thing. What to discuss about this case? Okay, because it's a totally neglected situation. 10-year-old child having achieved none of these milestones in any of this field, with the problems totally dependent on the current situation. Suppose there was something remaining, there is a role for your management. Here, what you can do at this stage is the question.
Immunization, child is immunized up to 5 years of age as per National Immunization Program. No optional vaccines were given and BCG scar was present. Diet history, the feeds are given via Riles tube by parents. The diet history was taken by 24-hour dietary recall method.
Whenever you are taking a history of all the postgraduates, unlike you are mentioning about each point in the history, you need to consider the special situation, each of the categories. When you're talking about the immunization, you need to stress on there's a chance of frequent infections in such a case. Not maybe not this case, another case where they are well managed, you can include other vaccinations to protect against the respiratory infections also. At the time he was born, there was no pneumococcal vaccine protection. And nowadays, influenza vaccines are coming. So you can add those things also in a susceptible way we like. Okay.
No vegetables are given. The diet is poor in micro and macronutrients. There is no exposure to sunlight and the child is not
receiving any vitamin. What is the method of feeding here?
Via Riles tube.
Riles tube feeding. So you can imagine what all will be, what is the maximum you can give through a feed Riles tube. There cannot be, there won't be fiber anyway. Fiber can't support enough of fiber like that. So that can be mainly, you can give energy source, maybe protein, micronutrients, if it is deliberately added. Otherwise, it won't be there can be deficiency in micronutrients unless adding each of these things deliberately, vitamin D, vitamin C, iron, are added like that. Otherwise, they will be lacking the micronutrients also. Okay. And one important, I was talking about the analysis, the assessment of the patient, the neurological problem, the deformities and sequelae due to this thing, and next comorbidities, neurological comorbidities like your seizures, intellectual disability, behavior problems, emotional problems, all neurological. And next thing, non-neurological associations like frequent aspiration and pneumonia, GERD, constipation, caries tooth, ear problems, skin fungal infections, callosities and bed sores, So all those things, because when you're managing, you need to consider all these things. So in the evaluation, the general examination, you should be looking for all these things. Infections, infestations, neglect, social problems. All these are part of the assessment, even though they don't consider be part of the cerebral palsy. Okay. And one point I was stressing was the constipation part. In a baby who is fed with it, constipation is very like constipation leading on to other problems also. Okay. Whether the baby was given deworming,
No, sir.
these are all important because this may be one of the reasons at midnight the child is crying daily. So that is one of the problems. A child waking up at night and not sleeping at all. Simple enterobase vermicularis, caries tooth, ear pain, fracture. So you need to consider all simple points. Okay, deworming is important. Okay.
He has a deficit of 614 kilocalories and 5 grams of protein. Family history, there is no history of seizures, developmental delay, or neonatal deaths in the family. No history of deafness, blindness, wheelchair-bound, or bedridden members in the family. Socioeconomic status, the father studied up to ITI, runs his own shop. Mother is a degree graduate and a housewife. They have a monthly income of rupees 25,000, out of which 6,000 is spent monthly on diapers and the dietary supplement powder. They belong to upper middle class according to modified Kuppuswamy scale. He has obtained disability or certificate. He is enrolled in Niramaya scheme and he is getting government monthly allowance.
Very, very, very good that you have mentioned a lot of social support. So we all should be aware of the programs basically meant for these disabled, not disabled. Now that word is out. Okay. So you need to know about this thing. How much is the amount that they are getting from the government? Suppose they are enrolled, they are having the UDID number. Niramaya is another scheme, but what they should be getting? How much they should be getting? What is support?
According to them, they have received only thrice, and the support was only in the form of diapers. No money was given.
What is the how much amount they are eligible? You know, they are eligible for scholarship, pension, annually 28,500 rupees they'll be getting, and for the mothers, what is the program? How much they'll be getting for the mothers? This is support for the mothers also. Ashwasa Kiranam. Okay, Nirama is another insurance thing, but lot many other benefits. It's the right. You need to know RPW Act 2016, and these are social support for all these group of people. Lot many other rights are there for the parents. So people, teachers may be asking, they are more interested about the caregiver burden of the mothers and the problem of the siblings, because they're all facts which we underestimate. The other siblings, how much they are suffering, about the mother's life. In this case, mothers may be educated, but she's not able to go for any other things. So how can we support this group? Also is another totally different aspect, but we all need to know about those things. The social aspect of the disabilities. Okay, that's very, very important. Happy that you have already mentioned this. Okay.
Summary. 10-year-old male child, third born of non-consanguineous marriage with no significant family history, born preterm at 33 weeks with a stormy perinatal course with global development delay, seizure disorder, feeding difficulty, and multiple contractures, who was non-ambulant on RT feeds, presented with fever, cough, fast breathing, and left ear discharge for 3 days.
Go ahead with the examination.
Examination, general examination. The child was examined in supine position. Child was sick looking and appeared wasted. Vitals, the pulse rate was 102 beats per minute, regular, normal volume, all peripheral pulses felt, and no radiofemoral delay.
So this is the point which I want to tell you. In the examination, I said your examination history should be going in hand. First thing is what you are doing now, vitals. You take the vitals, and if the patient is unstable, you need to address that. So if the patient is in distress due to aspiration pneumonia, maybe unconscious, maybe twitching of the seizure is control that. Maybe some treatable entities, maybe the micronutrient deficiency, hypocalcemia, tetanus. So address those things, take a blood sample for the hypoglycemia, hypocalcemia, electrolytes, and address those things. Then only start with the general examination. In the general examination again, it depends upon the status of the child. This is a totally bedridden child. It may be a child who is walking towards you. It may be a child who is on the lap of the mother. Another child may be in the bed. So depending upon whatever situation, your examination starts. Your eyes are the main thing. You are not touching, you are not doing the 180 flipping, you are not doing the taking the knee hammer, knee jerk, nothing. Your eyes are deciding. Your history you heard and your observation is trying to answer each of the questions which we are trying to answer. Is it a delay, development delay true? Is it a static disorder? What type of thing? And in the general examination, there are many clues which will be answering. Suppose there is a point in the general examination which is arguing for a degenerative disorder, like your skin changes or a hair changes, a large tongue, something like that, or a corneal haziness. That means it's not a static disorder, it is something else. So in the general examination, on seeing itself, you can tell that you are not dealing with it's a static disorder. Another one, peculiar appearance, dysmorphism, which may be arguing for a malformation, genetic problem. Genetic problem leading on to the development delay. There, what you are not is there a problem with the position, movement, tone? Cerebral palsy. So first question you are answering is there a problem of a position, movement, tone due to the insult? In this case, there is a definite insult. So these are the things which you need to answer. In the observation itself, you can get this clue. In the head to foot examination, whatever be the position, if it is on the lap, you start the inspection from behind and make all the findings from behind without touching the child. If the child is walking, you need to observe him. So observe about the posture and the movement and the gait. That will give not many clues. Okay. So what is you think it's an abnormal movement or a posturing, and upper limb is going into splaying and the torsion. That means there is a dystonia which is not fitting with your spastic type. So there is you will get a true walking, but there is a torsion element also. That becomes a mixed CP, not a
Spastic CP.
Observation about the position, posture, movement. It's all happening when you're taking history on itself, it's assessed. And during the history, they'll be playing with the mother, and you can have a development assessment. There is no extra time needed for the development assessment. During the history, you are giving something the way they are manipulating those things. So you can get an idea of the intelligence, how much, how he is handling this thing, about the manual ability scoring. So during those period, you are getting the baseline of the developmental thing. During the history, observation gives an idea of the baseline. What is next needed is you give try to titrate the higher level of achievement appropriately to know the developmental achieved thing, the developmental quotient, and apart from this thing, about the classification of the disability. What about the motor thing? Gross motor function, he is independently walking. He is in the wheelchair. That gross motor function classification, you know. And the manual ability, what all things he is doing. And you are talking the communication skill, and maybe from the history, and you can offer something, how he is taking it. Is there any drooling? The swallowing. So that again, eating and drinking classification system. And one more new thing which is giving more and more stress nowadays is the cerebral visual impairment. Previously, we were calling it as a cortical blindness. It's not cortical blindness. So more and more importance is given to a baby who can see, but he is seeing in a different manner. So more importance is given nowadays for the cerebral visual impairment also. All this assessment you are doing during this observation. Your touching and your manipulations and the reflex and all gives a little only. Okay. In the general examination, the clues about the associated problems like pneumonia, malnutrition, micronutrient deficiency, everything the clue is from the inspection. So you get a clue for the basic neurological problem in the form of what are the cranial, what is the limb problem of the tone abnormality, is it spastic, is it extrapyramidal, is there an abnormal movement? So neuraxis problem will get the clue from the inspection. You will get the deformity assessment from the posture again, the contractures, the bed sores, all the things, the scoliosis part. So that is the modification done by the neurology into the locomotor system. The other things, the non-neurological problems which happened due to pneumonia, due to micronutrient deficiency, due to malnutrition. Everything is by your watching. And watching, again, don't disturb him. Whatever manner the mother is holding or whatever he is doing. And last thing only, you will do the things which you need. Suppose in the beginning, I didn't see the friend. So you frame your examination based on the comfort of the child. So, madam, I wanted your comment.
Sandra, can I
Yes,
ask a
ma'am.
question?
Yes,
Sandra,
ma'am. Yes, ma'am.
how did you make out that the child was sick looking?
The child was tachypnic.
Tachypnea is not sick looking. Please prepare the answers for this question. Okay, you said the child was blind, isn't it?
Yes, ma'am.
No visual fixation
Yes, ma'am.
previously, isn't it?
Yes, ma'am.
In
No
which
visual.
parameter made you say that the child is just, this is a critical question, okay? You have committed that child was sick looking. Which made
yes,
you,
ma'am.
which parameter made you to say that the child was sick looking? Okay, after that you read and make the answers for this question. Okay.
Yes, ma'am.
Yes, continue.
Okay, continue.
This question given to you. Some tips that you have committed that child was sick looking. What made you to say that the child was sick looking? So there are parameters to say a sick looking child, whether those parameters were there or how many parameters were there, 1, 2, 3 or something. Just prepare it. Okay.
Okay, ma'am.
Continue. I am not giving you the answer. You have to prepare. Okay.
Yes, ma'am.
Being a PG, you have to prepare.
Head to foot examination. The shape of the head was normal. The size of the head was normal. Hair was normal.
Normal? Is it normal?
Shape is normal.
Size of the head?
Size of the head was normal. It was elongated, but the size was normal.
What is the head circumference?
Its circumference was 47 centimeter.
For a 10-year-old child?
Normal?
It was between -2 to -3 standard deviation.
What is the head circumference except for a 10-year-old child?
52 adult head circumference.
Adult head circumference is even more than 52. So anyway,
50.
it could be 52, 53. It's not 47. Definitely, head circumference is small.
See, I feel the shape of the head, there is frontal sloping.
Sloping also.
From the picture. That's Critically look. Okay.
No facial dysmorphism, large ears, active discharge from left ear, long eyelashes, eyes there was pallor, no bitoid spots, hemorrhages or cataract, oral cavity there was poor dental hygiene with dental caries, high arched palate, drooling of saliva, no gum hypertrophy, lips were normal, no angular stomatitis or cheilitis, neck was normal, no lymph
In this
nodes were
part,
activated.
1 minute, you go back to the other. In this part, micronutrient deficiency assessment is important because that can be associated. Okay, deficiency part, pallor, vitamin A deficiency, angular stomatitis, all these things can be there. This child was fed with a tube, so you missed some relevant finding. Otherwise, what is the other thing which you will be looking in a patients like this, in a development delayed child? Because the child was not fed tube feeds. Drooling. Okay. Drooling. Drooling is important because
Drooling is mentioned.
in this case, tube feeding may be, even then there will be saliva. Drooling. Drooling is important for your localization, many other ways. Okay. Caries tooth was there?
Caries tooth was there. Dental
That's also
caries was
important.
there.
Okay, important. What is the importance of all these things? The level of care. The mother maybe sometimes they may be not be neglecting the baby. They are looking after. That also is important. Very well.
Well, previous slide, you said the ears are large.
Yes.
Is it so or is it a relative? From the picture, I cannot make up. In which condition you think that the ears are large? Which not condition when something is there, you think that the ears appear large.
When there is
Yes.
primary microcephaly, the ears appear large and prominent.
Why? Why it is so?
Because of apparent.
It is
Because the-
just to know. See, because of the receding forehead, the ears appear very large, even though they are normal. So when you give a comment, you have to critically look at that. Okay. Okay, continue.
Neck is normal, no lymph node. Chest rachitic rosary was present. Spine, there was thoracolumbar scoliosis towards the right. No tuft of hair or presacral edema. Limbs, the upper limb, there was bilateral cortical
In this
fistula.
case, you need to look for all micronutrient deficiency, especially the bony problems like your vitamin D and scurvy. Very important. Okay. You are very likely to miss these two things because your physiotherapy and all, very easily bone can break, especially clavicles and humerus and all. Very important. Okay.
Bilateral cortical fisting, bilateral elbow contractures, lower limb, bilateral hip adductor, knee flexor, ankle flexor contractures were present.
Previous
External-
slide. Previous slide. What is obvious from this picture? Forget about the X-ray part. Take away that the hip
There
and
is a-
foot. Hip
There
and
is
foot.
there is a flexion contracture at the knee.
Hmm.
Then
You
there
said
is
the
the
bilateral adductor contraction and spasm. What do you think? What you observe that hip? What is it? What is happening? Hips are so important in a case of a development disorder of any sort, long duration hypertonia. In this case, the left side is adducted and internally rotated the hip. What about the right side? I mean, right side. Left side is not there. Maybe there is a problem of Winsett deformity. Winsett, you heard about Winsett? One
Yes,
side
sir.
is adducted, the other side may not be adducted but abducted. The position is very important because one of the problem here very likely is a dislocation of the hip. Okay, so hip assessment also is important. I think the left side, madam, what do you feel? Left side of the hip, is it adducted? Surma madam, കേൾക്കുന്നുണ്ടോ? Left hip, I think it's not adducted. Okay. About the knee contracture, you said a contracture. What else you should be checking when there is a contracture?
Sorry, sir, what?
This contracture.
Is it sir, I didn't get the question, sir.
The knees are 90-degree bend, and you said both knees, there is a contracture of the hamstring. Okay. So whenever you get the contracture, what should be assessed?
If it is a fixed contracture or a dynamic contracture.
Okay. How will you assess it? Suppose an orthopedician, how you will be assessing the orthopedician?
A fixed contracture will always be fixed, but a dynamic one can be moved when the patient is sleeping, and it can be mobilized, a dynamic contraction.
There is a purpose of this examination by an orthopedician. What sort of a treatment is needed? How he will be assessing orthopedician?
A dynamic contracture can you can give an medication like medications, but fixed contracture will require surgical management.
Okay. You decide about the surgical or medical. Okay. What is the test you are doing? There is R1, R2. You heard of R1 and R2?
Yes, sir. Tardo scale.
You stretch the joint fast. Okay. And a fast component, and then followed by a little more you do it. So if it is stretchable a little more, so these are the two components. The R1, R2 are the same, means it's a fixed contracture. No more of the spasm contributing, it is a deformity occurred. So it just stopped with that. There is no more of this stretching possible. R1 and R2 are same. A little more of stretching is possible. R2 is more than R1. There is a muscle spasm element that can be addressed medically, either systemic or a local. Okay. So if R1 and R2 are same, there is no point in using those spasmalizing medicines and botulism, whatever. So you need the surgery. So orthopedician will be doing this thing before you decide about the management. So here you need to do that in that angle. It seems more like an established contracture. There is not much role for your medicines. Very, very important, because you will be naturally giving him on baclofen, dantrolene, or designed whatever. It won't be working because the spasm contributing there will be minimal. Very, very unlikely that it is contributing. Established spasm. If at all you want to do anything, it's still surgical only. Okay.
External genitalia, bilateral testes were distended, skin was dry, no neurocutaneous markers or pressure source, no abnormal body smell, SMR stage 2. Anthropometry, weight was 11.6 kg, which was less than -3 standard deviation, severe underweight. Segmental length was 124 centimeter, -2 to -3 standard deviation, stunting. BMI was 7.5, severe wasting. Head circumference was 47 centimeters.
So all these assessments are actually non-neurological sequelae of these problems. So I was talking in the assessment. So what are the relevance of this part of the assessment? When you're planning, there are a lot of things you can do for any baby. So here you can address the nutritional part, micronutrient deficiency, supplementation of the other deficiency problems, calorie, protein, everything can be done for any child. So you can treat the complications like pneumonia, whatever. You can treat the nutritional part. So how much all these problems are there in any child you can do. In a neuro regression also you can do. In a very bad situation of the static disorder also you can do. You can't decide that nothing can be possible because the child is precious for the parent. So don't say that I can't do anything. We can address these things. So that should be a positive attitude, even in this case. So these are areas where you can do something. Okay.
CNS examination, higher mental functions, eyes were open, turns head to side, responsive to pain, and moves limb away from site of pain. Attention, concentration, intelligence, and memory could not be assessed in view of poor cognition. Cranial nerve examination, cranial nerve 1 not tested, cranial nerve 2 pupils bilateral.
Question, which are the cranials you'll be discussing on in this case like this?
Cranial nerve 2.
You will need be assessing the vision and the fundus, definitely.
Fundus.
Okay, you are not sure about the vision. Fundus is normal. Okay.
Normal.
What is the most important thing Madam was asking previously?
Sick looking.
Pupils. Pupils. What does the pupils like? Reacting to light?
Reacting to light.
What sort of a visual problem is here?
Cortical blindness.
So anterior segment normal. Pupillary light reflex is the normal fundus. Okay, still the patient is not seeing. Maybe it's too much of a cognition problem also can lead to. You may not be interested at all. That also is very possible. Okay.
Then the next important cranial nerve to focus on will be cranial nerve 5 to look for jaw jerk.
No. 3, 4, 5 also. 3, 4, 6 also. Because in 3, 4, 6, it won't be the paralytic type of squint. You'll get a squinting in a case of especially which type of CP you get a squinting and the ocular problem?
Chorioepitoid.
No, hemiplegic type of. Okay.
Cranial nerve 9 and 10, the uvula is central, bilateral palatal movements are equal, gag reflex is present. Cranial nerve.
Here you said there is a swallowing problem, frequent aspiration. You said jaw jerk is exaggerated. Okay.
Yes, sir.
Jaw jerk is exaggerated. What do you expect about the other reflexes? Jaw jerk and the gag reflex?
Gag reflex is present.
Present or exaggerated? Usually exaggerated.
Exaggerated.
Could you do the gag reflex and all in this case?
Yes, while putting the RT tube.
Very likely that it will be also be exaggerated. Okay.
Cranial nerve 12, bulk and size of tongue normal, no deviation of tongue or fasciculations.
Do we expect a deviation of the tongue or face in a case like this? So then naturally when your PGs will be presenting, to say that there is no facial involvement, you will be telling no deviation of the face. Do we expect a deviation of the face or tongue in a case like this?
No, sir.
Very unlikely. Even if it is a hemiplegic type of a CP, a deviation of a tongue or a face will not be there. Okay. Very unlikely. If at all you are getting the UMN, it will be bilateral situation. Okay.
Posture, upper limbs adducted at shoulder, flexed at
So
elbow.
how will you assess a facial weakness in a child, not this child? What questions will you be asked? What will you be assessing?
When the child sleeps, does the child sleep with both eyes open, or it is one eye, both eyes closed, or is one eye open? If there is any obvious facial deviation on chewing.
If it is a bilateral, my question is, how will you assess a mild bilateral weakness? It's not relevant in this case. It's a different question. Which function will be disturbed? The
emotional lability will be.
No. It's so you can use the straw, the sucking and blowing. Okay. So those are the few points which you can ask about the child. Straw, using a straw, blowing, those will be defective. And doing and food material going outside when you are chewing. So the subtle bilateral weakness. There won't be deviation in the case. In this case, none of these things will be there. Okay.
The upper limbs are adducted at shoulder, flexed at elbow, pronated, flexed at wrist, flexed fingers with cortical thumb. Lower limbs adducted and flexed hips, flexed knees with plantar flexed and equinovarus deformity of ankles. Bulk was same in right and left upper limb and lower limb.
Here again, when you are assessing, you need to assess the deformities of the different parts, especially the hands. And so you said the fingers, cortical fisting. What about the fingers? Status of the fingers, whether there's a dislocation already has happened. Because nowadays the surgical management for the hand alone, there are specialists, CP child and all. Many things you can do for a child, not at this child. Cognition better, child with some deformity, and surgical intervention can help them. And how to improve the eating and drinking problems by the surgeon and the occupational therapist, because that makes a lot of difference. Self feeding is very, very important. So modifying the spoon, the other utensils you use, the method which will be helping for self-feeding, modifying the finger use by surgical other maneuvers. So many other things are appliances are there also helping. So what way I can help this baby to be independent in different day-to-day activities? So you need to be looking for that. So what about the posture of the hand at the knee joint, elbow joint? So what remedial measures can be done to improve the position, whether done by botulinum toxin, whether done by the mere tendon release or tendon transfer. So all these are planning based on your assessment. It's not enough to see the knee jerk, ankle jerk. So naturally you'll be doing only those things and you're moving forward. It's not a neurologist approach. It's a different approach. For a developmental pediatrician, the approach is different compared to a pure neurology, because many deformities has occurred, and how to help him out from this thing should be your view. Okay.
Tone posture as described, palpation, all four limbs were stiff, fixed contractures of bilateral elbows, hips, knees, and ankles, passive movement, upper limb and lower limb. The tone was increased in both right and left. Power.
In this case, again, one more thing which we are discussing, you need to decide 1, 2, 3, 4 by stepwise. In the one stage, you need to answer the topography. In this case, it's a quadriplegia, no doubt. Anatomically, all the four limbs are involved, including the lower cranial, pseudobulbar palsy. Next thing is the physiological. What is the tone like? Is it a pyramidal only or an extrapyramidal? So when you are assessing the tone, there is a scale of assessment of the tone, whether it is a spasticity only or there is an element of extrapyramidal. Okay, hypertonia, is it spasticity or the other one or a combination? So all these things are assessed by the different techniques. How to differentiate whether it is a one of the very, very eminently treatable thing, and one of the mistake is a missing of a purely dopa sensitive dystonia for a diplegia. So what are the clues that this particular extrapyramidal or spasticity, the hypertonia is not spasticity but dystonia, this thing, pyramidal? What are the clues?
Spasticity is velocity dependent. Rigidity is not velocity dependent.
Right. Then
rigidity will be present in all directions, and spasticity, because both the muscles are involved, both the agonist and antagonist muscles are involved, but spasticity on both groups are not involved. In rigidity, it will vary from time to time and from examiner to examiner, but spasticity will not. Rigidity, the patient will not have contractures, but spasticity will have contractures. Spasticity is clasp 9 and rigidity is lead pipe.
And the sleep during the sleep and relaxed period, sleep will be persisting. Very good. Okay. In this case, it's very important. What do you think in this case? It is spasticity only or is it a combination? Is there any torsion movement?
No torsion, no twisting movement.
So it's a purely pyramidal only.
Pyramidal.
Okay, go ahead.
Power of muscles, the power
of... just 10 more minutes, Monasa. Okay.
Okay, sir.
The power of all muscles was less than 2/5, except for flexion at shoulder and flexion at elbow, which was 3/5.
I'm not concerned about this power part. Whether you can test and grade the power just like any other muscle assessment in the presence of a contracture of this extent. Susuma, Madam Poya. I don't know whether it is possible to say grade 1 like that in the context of this much of contracture. Mohandas, what do you think?
What's that, sir?
In
Contraction.
the presence of this much of contracture,
Hmm.
the grading of power
It will be really difficult.
very difficult.
That is not needed
Real
also.
time.
It's not needed
All right,
also
okay.
for this child
Okay.
who is has not attained any development.
Okay.
I don't think that sort of finer details about muscle power are not very
Not
important.
not very helpful for the manager. Here again, one more point. Yeah, about the reflexes. You read the reflexes.
Jaw jerk is exaggerated. Biceps and triceps could not be elicited due to contractures. Supinator was present,
That
but
is the point here. Yeah, you're very, you should be very careful when you're mentioning that. What basis you said supinator is 3 plus when the biceps could not be elicited? What are the components of the supinator? Jerk?
brachioradius.
When you are eliciting the supinator, there are two things. Okay. One is supination, flexion happening at the elbow. There is the inversion component. Okay. So how can there be, can you expect a biceps could not be elicited because of contractures, but the supinator is 3 plus. That's not possible. Okay. Unlikely. Okay.
Corneal and conjunctival reflexes were present in both right and left eye. Plantar was Babinski positive in both. Abdominal and cremasteric reflex was present. Primitive reflexes were absent. Stance and gait could not be assessed. Abnormal movements were absent. Sensory system could not be assessed. Cerebellar, no titubation, nystagmus or intention tremor. No signs of meningeal irritation. Skull and spine, skull appears normal.
In this case, meningeal irritation, no signs of meningeal irritation is relevant. Okay. In other situations, actually, list of these things, even though in the neurological examination you mention all these things, there are certain things which are not much important in developmental delay problems. Features of race ICT, signs of meningeal irritation are not much of important because developmental regression, developmental static disorder and all, race ICT meningeal irritations are very unlikely. If at all you are getting a sign here, but must be due to the problem of the skeleton, the spine problems only. In this case, it is important. Why? Signs of meningeal irritation is important in this case. Why? What is the problem for which the patient was admitted here?
Pneumonia.
It wasn't the only problem.
Fever, cough, fast breathing, and a left ear discharge.
When there is an ear discharge purulent, that's very important. So that is one point which you need to consider. A child with cerebral palsy admitted, all your attention will be in other directions. There may be treatable entities which are missing. Child with ear discharge, excessive cry, and seizure. You are taking the seizure as a part of the CP. Child is having fever, you are taking it as a part of pneumonia. You never consider this as a concept and be any other child with ear discharge, there can be meningitis also. So signs of meningeal irritation is relevant here. Okay.
Yes. Other systems, respiratory systems, breath sounds were decreased in the right mammary, axillary, infraaxillary, inter and infrascapular areas. Bronchial.
Okay, pneumonia part. Okay, go ahead. Go forward.
This is the MRI brain. MRI brain on.
I'll just try to interpret that MRI brain. Okay, for you. This panel shows the upper is a, okay, the lower one without contrast, upper is a T2 image in the upper panel. So a little bit of a dilatation of the both ventricles. Okay. Yes, and the cerebellum is normal. The medulla, pons and midbrain, they are all normal. Both sides, ventricular dilatation is there. And overall, there is an atrophy. Atrophy, bilateral atrophy, sir. So atrophy is responsible for the dilatation, and there is a periventricular brightness bilaterally. So atrophy is significant. That is responsible for bilateral dilatation. The basal ganglion thalamus part is normal. The cerebellum is normal, and the brainstem part is normal. Go to the next slide. So here comes your sagittal cuts. Sagittal cuts in the first part. I think the corpus callosum is thin. Thinning of the corpus callosum is there, and the other things, atrophy is there. And I have seen a few small cavity-like situations in the one of these things in the front part. You move on. One more slide is
No, sir. Only this.
I have seen somewhere near the frontal horns a little bit of cavitations were there. So yeah, I think there's a possibility of an underlying migration disorder also in this case, like corpus callosum thinness, apart from the features of general atrophy. Okay, what was the report?
The report says periventricular leukomalacia with cerebral atrophy with dilatation of the lateral ventricles and prominence of the posterior horn of the ventricles. There is thinning of the corpus callosum.
Right. Okay. So most likely it's not a HIE only, there is an underlying problem. That must be responsible for the intractable seizures, including myoclonic seizures also. So migration disorder as an underlying problem is the, okay. Go to the next slide.
EEG then showed focal epileptiform abnormalities over bilateral posterior head region and independent epileptiform abnormalities over the right occipital region, along with asymmetry in electrical activity over the left hemisphere. Summary: 10-year-old male child, third born of non-consanguineous marriage, who had delayed attainment of milestones with convulsions and cortical blindness, not attained speech and no deafness, with a non-progressive deficit in the form of spastic quadriplegia and a developmental quotient of 0, probably spastic cerebral palsy with perinatal insult in the form of prematurity, low birth weight, and respiratory distress with complications like contractures, scoliosis, and pseudobulbar palsy. He is currently admitted with pneumonia and left ASO. The diagnosis is global development delay, static encephalopathy, spastic quadriplegia type of cerebral palsy with fixed flexion contractures of bilateral hip, knee, and ankle, and dynamic contractures of bilateral elbows due to prematurity, low birth weight, and perinatal respiratory distress, cortical blindness, epilepsy, and thoracolumbar scoliosis and pseudobulbar palsy. Severe wasting, GMFC is grade 5, MAC is grade 5, pneumonia, and left ASO.
I think we'll discuss about the management part in another session. That's
Sir, can I ask a question? Can I ask?
Stop sharing, Sandra.
Can I ask a question?
Yes.
Why it is a static encephalopathy? Because the child is now 10 years. Child has not attained any milestones. So static, usually we say the child gradually attains milestones. So why do you say it is static?
Child gradually attains milestones, but this child also has seizure disorder, which could have been responsible for the pseudo regression and not attaining the milestones.
Actually, there is no regression. Child
There is
has
no
not
regression.
attained any
It
milestones.
remains not attained any milestone. The child also has contractures, hence the child has not lost or attained any milestones.
I'm not sure whether we can, for sure, we can say it is a static disorder or a progressive disorder. It is difficult because if the child has attained some milestone,
But the child attends to the mother calling him. That's what you said once.
Yes, ma'am.
Recognizes the mother's voice or something you said.
Recognizes mother's voice.
Well, I have a question. Anybody? Regarding the nutrition, what is the Sambe protein? Who prescribed it?
It was not prescribed by us. They
What is this? What is the relevance or the merit of giving the Sambe protein to the child?
Madam, there is no benefit. There is no benefit, but it is taking a toll on their financial situation because the bottle itself is 1,900.
Ah. So somebody would have given them a direction. Okay, thank you. If you were looking after the child, how could you have given micronutrients to that particular child, this particular child?
Micronutrients could have been supplemented as separate in the form of tablets, which could have been added with the food, and there could have been involvement of more fruits and vegetables, which could have been mixed.
Or is it that you prepare a family pot diet and use to mix it, use a mixie and grind it and give it to, anyway, everything is being given through the tube, isn't it?
Yes, ma'am.
The amount of money they spend for the Amway proteins, they could have used the whole house family's food with that amount and also feeding for the baby child without any problem, that is micronutrient or any deficiency, if it has been properly designed, isn't it?
Yes, ma'am.
Probably the Amardam powder, which is given free of cost, will be having equal nutritional value.
Any other contribution from Dr. Dali, Dr. Shiji? Ji, undo.
I think Sandra has presented well. And
it's a difficult patient with so many findings.
Yes.
But your ability will be to bring all these things within the stipulated time.
And the more important aspect may be what are the areas where you can do some interventions, how to make the life of the child, or more than that, the life of the mother more comfortable regarding feeding and all, and like that, rather than the minute neurological aspects, which is not going to help either the child or the family, because even at 10 years, child has not attained significant milestones and the prognosis is going to be very bad. So the more important is to, in the aspect of activities of daily living.
So we can wind up, I think. Thank you, Sandra.
Thank you.
You presented very well. Thank you, Susma madam.
Thank you, sir. Good night. Good night, madam.
Thank you. Thank you.
Thank you. Good night. Good
night. Good night.